Ya estamos inaugurando esta posibilidad de traducción automática de una charla que es parte de nuestro pilar de internacionalización. Pero es un muy buen momento. A nombre de la Facultad de Medicina de la Universidad Católica del Norte, quiero dar la bienvenida a este evento, que es una clase magistral de vinculación con el medio, donde tenemos la oportunidad de con un invitado estelar y de fama mundial en el área, que lo presentarán a continuación. Una oportunidad en que tenemos en el público tanto a estudiantes de pregrado, de medicina particularmente, estudiantes de posgrado de las especialidades médicas y docentes, ¿ya? Docentes clínicos muy interesados, estamos felices por la convocatoria que ha tenido esta actividad. Agradecer al programa de imagenología, en particular la doctora Marisa Sangüesa, su jefa de programa, el doctor Rodrigo Araya, quien realizó la gestión hoy con este evento. Agradecer también a todo el personal de apoyo de la universidad, ¿ya? Tanto de informática como de la Facultad de Medicina. Detrás de este evento hay un esfuerzo importante y cariñoso de todo nuestro personal de apoyo. Y en particular dar la bienvenida al doctor Michael Lepp, quien será presentado como corresponde por el doctor Rodrigo.
Muchas gracias, doctora. En primer lugar, gracias por estar acá a todos los presentes. El doctor Michael Lepp es neurorradiólogo de Mass General de Boston, es profesor de la Facultad de Medicina de la Universidad de Harvard, y él está acá por un programa que participamos hace un par de años, que se llama un programa visitante de la Sociedad Americana de Neurorradiología Diagnóstica, y ganamos 3 años, y el doctor ya está en el segundo año visitando, es el doctor que está visitando como en segunda oportunidad en Chile, y en este año estuvo en el Congreso de Radiología, y en esta oportunidad está visitando la 4ª región, visitó el hospital de Coquimbo en la mañana va al CDT, y el día miércoles va a Clínica Elqui, además de algunas actividades extraprogramáticas. El concepto fundamental que hay detrás de esto es aprender del Dr. Lepp tanto su conocimiento como sabiduría. Tiene muy buenos consejos, así que les recomiendo escucharlo con mucha atención. Muy importante lo que dice, llévenselo a casa, aprendan de accidente cerebrovascular, y en segundo lugar mencionar que la Universidad Católica del Norte demostrar que podemos pensar fuera de la caja y tratar de buscar conexiones fuera del país, o una especie de networking con gente que trabaja afuera y que piensa distinto. Es sumamente importante ver cómo piensa el otro y tratar de mejorar y tratar de compartir experiencias y conocimientos. Así que de eso se trata la universidad, y ustedes son parte de la universidad, así que los invito a poner mucha atención y disfrutar este momento. Así que bienvenido, doctor Lepp.
Okay. Okay, well, I didn't understand most of that, so I assume it's good because everyone clapped and no one walked out, so thank you very much. It's really a tremendous honor to be here. It's my first time in Chile, and so far I'm absolutely loving it. It's just terrific. And as you heard, I'm going to be talking about stroke, and they say that you probably only remember at most 10% or the 3 or 4 most important things from every talk, but I'm only going to tell you the 10% you need to remember. So basically, I don't have really any conflicts of interest. I'm not going to be talking about any specific types of CT or MR scanners, but I do work with General Electric. And basically, this is the slides that I had from having just visited the Congress in Santiago. And I think if you remember nothing else from the whole talk, and I've already spent the morning with many of the residents over at the medical center, I think the most important thing that you all want to remember is that you need to be doctors, not technologists, and not just people who look at a certain lab test or look at an X-ray or a CT scan, but see the whole patient. Because if you don't, ChatGPT is getting so good that, and I'm serious, that you're going to get redundant. You're going to not be needed. And there's things that it can't do. But right now, even if you put, you know, we tried this morning, what is the differential diagnosis of terminal ileitis? And it comes out with a brilliant differential. But what you need to do is know enough of the clinical history, of the lab tests, of the patient's past medical history to synthesize and put everything together to order that differential diagnosis and to decide which of this list of things is the most likely. Because if you can't do that, then you will get replaced by AI. And what I like to tell our residents and fellows is that AI, don't think of it as being artificial intelligence, think of it as being augmented intelligence, and that it's a tool that you use to make you smarter and more efficient. So you don't have to waste time memorizing a lot of things. That's what the internet is for. But you do have to understand the diseases and the physiology, and most importantly, the most important thing is, for especially in neurology, but really for everything, is how are things changing over time? And not just how are they changing, the degree, but the rate. If things are getting worse fast, you might be dealing with an infection or a tumor. And if things are getting worse slow, it might be a benign, slow-growing tumor or some other inflammatory process. So the rate of change is very important. So think about not just that time stamp, that time point when you see the patient. You have to take it in the course of their history. And especially important in stroke is it a sudden onset, like snapping your fingers, or is it a gradual acute onset because you're thinking about different disease processes? You need to know the exact reason why any imaging test is being ordered or lab test, because if you don't know the reason for the study and if you don't know the question, you're not going to be able to answer it. You have to know what it is you're trying to answer. And I want to just talk a little bit about acute stroke in general. And there are lots of different causes for stroke, but basically what is not on this slide, but what I'm going to tell you right now, simple things like diet and public health and control of diabetes and control of high blood pressure, at the end of the day, are the most important. And so I always tell my trainees, if you see a little punctate infarct in the basal ganglia and the caudate or putamen or globus pallidus in the brain, the deep gray matter nuclei in the brain, a punctate stroke is a focal hypodensity, or a focal lesion on a diffusion scan is usually from high blood pressure. And you know what? If you take all these different causes of stroke, 70% of them would be completely eliminated if you just were able to control high blood pressure. So if you're a radiologist and you're reading a brain MR or a head CT and you see a new lacunar infarction that is probably due to high blood pressure, put that not just in the report, but put it in the impression. because even if you look up in the medical record that this patient is on antihypertension drugs, it means if it's new, they might not be on a high enough dose, or they're not taking it, and they're non-compliant, and it's not controlled. So little things like that make the biggest difference. And so by putting it in the impression of the report that this is not just, there's a new focal hypodensity, it is likely a lacunar infarct due to hypertension. By adding that it's due to hypertension, you're letting the referring provider who ordered that scan know that the blood pressure is probably not being well enough controlled, and that patient is getting new strokes, and they may need better blood pressure control. And by putting in those kind of things, you are not only communicating to the referring provider, but radiologists have two customers. And our primary customer is always the patient, but when you're a radiologist, it's a service industry, and the customer you're really trying to communicate with is the person who ordered the scan, is the referring provider, and you want to let them know what is going on. And so I once gave this lecture to an audience in Bangkok, Thailand, and I gave a 1-hour lecture, and I talked about all these things, and I said that the biggest cause of stroke is either cardiac embolus or carotid artery atheromatous disease, atherosclerosis, and carotid artery disease in the neck. And after giving that whole lecture, this neurologist in the front raised her hand and said, "Dr. Lev, that was a great talk, and I'm sure it's good if you're lecturing in the Western Hemisphere, in North America, but here in Thailand, we actually don't eat at McDonald's, and we don't have a lot of atheromatous disease. We have things like moya disease. We have inflammatory disease that cause intracranial atherosclerotic disease and viruses and things like that." And so I gave this whole lecture, and I wasn't talking about the right demographic. So every region has its own unique demographics and epidemiology based on genetics, based on diet, but I'm going to assume that you have McDonald's and you eat fried food and you eat a lot of fatty pork and that what I'm talking about is going to be relevant here, but if it's not, someone shout out and stop me, because I want to talk about what's relevant. But at least for us, heart disease has really replaced the carotid artery disease as being the biggest cause of embolic stroke. What do you mean by embolic stroke? You mean that there's an embolus, a blood clot, that is a thrombus that has formed outside the brain that is traveling to the brain. So when you have a heart attack, it's really in situ thrombosis. It's coronary artery disease in the end organ that is causing the lack of blood supply, lack of oxygen that leads to infarction, that leads to myocardial infarction. And it used to be that this carotid stenosis was the biggest cause of embolic stroke. It was called artery-to-artery embolus, but we've gotten so good at screening for carotid artery disease and doing carotid endarterectomy and stenting and medical treatment on Plavix and antiplatelet agents and blood thinners that the medical treatment of this carotid disease has become very good, and we're seeing much less of that. But AFib, something like atrial fibrillation, where a clot could form in the left atrium appendage, is becoming a much more common cause of stroke, and people still have a lot of heart disease, and so that's replaced it. But again, these small vessel lacunar strokes are the little strokes due to end vessel disease, due to chronic hypertension. And that makes up a lot of this. And at least 20% of all strokes, we never really find the cause. They're strokes of unknown origin. And those strokes of unknown origin, up to 40% of them are from atherosclerotic disease in the arch. And I know a lot of people here are students and don't specialize in neuroradiology or don't specialize in neurology or stroke. And so I want to keep this general, but when you're doing the arch disease and looking for it, it is part of our scan protocols. And if I want to get technical about how we image these things, I think the standard right now is to do a CT scan. And as you'll see, if there's a big theme of this talk. And one of the themes of this talk is that non-contrast CT has an enormous amount of information, and just doing a CT without adding any iodinated intravenous contrast could tell you so much. But we do, for acute stroke, if it's a rule-in stroke rather than a rule-out stroke, we do a CT angiogram of the head and the neck, and that CT angiogram means we're giving contrast and we're looking at not only the arteries, but we'll get delayed contrast enhancement and we're looking at the veins. Because whenever you have an atypical stroke, something not in a usual pattern, there are both arterial causes of stroke and venous causes of stroke. And a venous sinus thrombosis is another big cause of stroke. And it presents a little differently. The imaging patterns, the parts of the brain that are affected are different. And the demographic is a little different. Who gets venous strokes? People who are on birth control pills. It's often estrogen related, postpartum, prepartum. People who have cancer and are pro-coagulant, who are more prone to make blood clots, can get these venous thromboses. So if you see, I'm going to show you in a little bit common patterns of arterial stroke, and they're easy to guess. It's what artery is going to what part of the brain, and if there's an embolus or a clot that travels up into that artery, you get a stroke in that location. But venous strokes are more subtle. They're about congestion, and they happen over a much longer period of time. It's not like with an arterial stroke, it's like snapping your fingers. The embolus goes up to that part of the brain loses oxygen, whatever the function is of that part of the anatomy, that function stops working. And again, it's crossed, so if it's an embolus on the left, you're going to get weakness or symptoms on the right, and vice versa. The venous infarcts could be over more time because it's sluggish venous outflow, and it could be 24 to 48 hours of venous congestion before that tissue starts to infarct. And once it infarcts, the capillaries can break down, they become friable, and it could be hemorrhagic. And even if you see a hemorrhagic venous infarct, it's almost paradoxical, it's a bit ironic, that the treatment for a hemorrhagic venous infarct is actually heparin. It's Coumadin, it's blood thinner. Because the treatment for a hemorrhagic venous infarct is to get rid of the clot and the congestion so you could have good vascular outflow and reopen the normal arterial venous flow through the brain. With an arterial stroke, the single absolute contraindication to any kind of treatment with a catheter where you suck out the clot, EVT, endovascular thrombectomy, where you put a catheter up, Seldinger approach through a femoral artery in the groin, you thread the catheter up in the brain, you do interventional neuroradiology, and you pull out the clot. With an arterial clot, if there's already a hemorrhage, you don't want to do it because it's under arterial pressure. And if you reopen a vessel that's occluded when there's already a bleed, that bleed is going to get bigger. It's going to extravasate. Whereas a venous infarct, it's not under arterial pressure, it's under venous pressure. The treatment is to relieve the venous pressure. And the only way to relieve the venous pressure is to get rid of the clot in the veins so the blood can flow out. And that congestion is relieved. All right? Now, a lot of different patterns. And the other thing is, I just, again, spent the whole morning saying multiple times to the residents and the fellows that it's very important to know the demographics. There are different differential diagnoses, different common diagnoses in men and women, in young and old. And for those of you who know a little math or statistics, it's actually called Bayesian statistics, where you look at the probability of disease based on what you see on the images and based on the clinical history, but then you modify that based on other factors. What is the pretest probability? And that's where knowing the history helps. And so, for example, in a young person, when I hear the word chiropractor, I don't know how many chiropractors you have here, but as soon as I hear the word chiropractor, I just have to hear that one word. I know I'm looking for a dissection. And especially if you know your neuroanatomy, I'm not going to get in the weeds, I'm not going to get too granular about it, but when the vertebral artery crosses from C1 to C2, it's actually uncovered just before it goes into the foramen magnum. And if you have a chiropractor that's doing deep muscle massage in the back of the head and presses on the vertebral artery just against the bone, very easy to cause a dissection. I'm very frightened of chiropractors. And I saw one just a few weeks ago. It was a dissection in the distal vertebral artery, and the history was chiropractor. I have a lot of one-word diagnoses. All I need is the one word. That's why you need the history. Here's another one, worst headache of life. What's, not one word, few words, but close enough. What's the diagnosis if you hear worst headache of life? Sudden onset, worst headache of life. It's a ruptured aneurysm with subarachnoid blood. That's what causes the worst headache of your life. What causes a thunderclap headache? What is a thunderclap headache? A thunderclap headache is like lightning and thunder. It like goes up into a crescendo, gets loud. There's a thunderclap. The lightning forms. By the way, the speed of sound is 5,000 feet per second. So when you hear thunder and lightning, you could time between the thunder and the lightning and divide by 5, and that tells you how many miles away the lightning is. So thunderclap headache is RCVS, reversible vasoconstrictive syndrome, where the vessels go into spasm. What causes that? Some of the same things that could cause venous infarct, like progesterone therapies, certain drugs. The biggest thing is SSRIs. A lot of the serotonin antidepressants can cause vessel spasm and can give you these thunderclap headaches where the vessels go into spasm. Weightlifting, postcoital. We've had patients had dissection postcoital. It happens. It's important to know. If you see the word transatlantic, someone's on a plane, they've been on a 10-hour trans-Pacific or transatlantic flight. As soon as they get up from their seat in the plane, they have a stroke. What's the diagnosis? You don't really need to do the CTA and the echocardiogram, and they got a DVT. The DVT, when they stood up, traveled up into the heart. They have a PFO, a patent foramen ovale, atrial septal defect. So DVT, paradoxical embolus through the PFO. Just having a little teeny bit of history saves you so much grief, saves you so much time. Knowing the reason for the study, the important clinical history, how focal the neurologic exam is, tells you so much. Okay, and The reason that atrial fibrillation has become a much bigger cause of stroke is that it's unpredictable. You know, if someone has carotid stenosis, you can test for it, you can put them on medical therapy or do stenting or do an endarterectomy before they get their stroke, so it's preventative. It's very hard to predict when someone is going to be in AFib. It's harder to prevent, which is why we're seeing more embolic strokes coming from the heart due to atrial fibrillation. But you know what? On a CT scan or even on an X-ray, you could always tell if there's probably AFib, at least in the extreme. It's very specific, but it's not very sensitive. But it's how big is the left atrium? Because when the left atrium gets cardiomegaly and enlarges, it stretches the SA and the LA nodes in the atrial wall, and those are the pacemakers for the heart. They control the heart rhythm. And if they're stretched, they stop working. And there's a very simple measurement. If the carinal angle, the left atrium sits right under the carina. You have your trachea, you have your right mainstem bronchus, your left mainstem bronchus. If the carina is normally about 90 degrees less, if it's more than about 100 degrees, you probably have left atrial enlargement. And if it's really straightened out, you definitely have left atrial enlargement. And if you definitely have left atrial enlargement, I guarantee you, you're going to be in AFib. You will be in AFib, and there's measurements for that. If you're looking at a CT scan, you could look at the anterior-posterior diameter of the left atrium on a CT scan. If it's more than 4 centimeters, you're more likely than not to be in AFib. If it's more than 5 centimeters, you're definitely in AFib. And if you ever see a case where the left atrial diameter, AP, is more than 6 centimeters, everyone has my email, send it to me, we'll write a paper together, because that would be a case report. Okay. There's some very rare causes of stroke. So there's stroke mimics, which you should be aware of. And those stroke mimics include hyperglycemia. Now normally, I know that the students probably don't know how to read a head CT. I'll give you just a super quick lesson on how to read a head CT. Basically, head CT measures density. The denser something is, the brighter it looks on the image, the pixels. And it really, you could divide it up into 4 tissues. If it's the brightest possible pixels, it's probably calcium, like bone. If it is a little bit of bright, it could be some blood clot, but there's a lot of variability there. And there's actually a scale for that. It's called the Hounsfield scale. So 0 Hounsfield units is water. Anything close to 1,000 or above is calcium, is bone, is very dense. Gray matter is about 35, white matter is about 25. Soft tissues are usually less than 100. Unclotted blood is probably 20 to 30, but fully clotted blood, if you just took a test tube of red excuse me, if you just took a test tube of red blood cells, it would probably be about 100 Hounsfield units. Which is also very interesting because for the radiologists in the room, if water is 0 Hounsfield units and a test tube of pure red blood cells is 100 Hounsfield units, what is the definition of hematocrit? Have you all learned how to measure hematocrit? If I take my blood right now and put it in a test tube, what do I do to that to measure my hematocrit? I put it in a centrifuge, I spin it down, the percent of what's in that test tube of the layering red blood cells is my hematocrit, and the rest is water, is blood plasma. So if my hematocrit is 40, it means that there'll be red blood cells up to about 40% of the height of that column, and the rest, the 60%, will just be water, will be plasma. That's my hematocrit. If water is 0 Hounsfield units and pure red blood cells is 100 Hounsfield units, it means you could just take a region of interest and put it over the aorta, and you could pretty much estimate the hematocrit. And I encourage all the radiologists to try that. Take a region of interest on a non-contrast CT of the chest, put it over the aorta, and it'll be within plus or minus 3 or 4 of the hematocrit. So you can actually, don't even have to do the blood test. You could measure the hematocrit off the CT scan. But in that case, hyperglycemia can cause a little high density that is kind of like a stroke or a stroke mimic. CPM means central pontine myelinolysis. For those of you who know what that means, great. For those of you who don't know what it means, it's another cause of osmotic stroke where someone gets too hemodiluted. But again, I think the main point, and it's usually in the pons, which is why it's called central pontine myelinolysis, but you could really get it in other parts of the brain. And I already gave you the answer to this, but for those of you who follow the New England Journal of Medicine, we have every issue that comes out has a CPC, a clinical pathology conference, where they take some interesting unknown case, and there's always at least 5 authors, and each of the experts, one's a pathologist, one's a radiologist, one's a neurologist, one's a general practitioner, and they all are very erudite, and they discuss the case, and it's multiple pages long, and they give a long differential diagnosis. But all you have to do is look at the title of this case, and you already know what the answer is going to be. You know, keep it simple. Keep it simple. This was a woman who had a deep vein thrombosis and got up from her plane, and she threw an embolus, and she had a stroke. And it's a paradoxical embolus from a DVT through a PFO. And I told you that I would show you all the different patterns. And again, for the neuroradiologists in the room, this is very meaningful. But this is the circle of Willis. This is the neuroanatomy of all the arteries in the brain. And I think the main point for those of you who aren't familiar with this is that you have 2 carotid arteries that are in the soft tissues in the front of your neck, and these are the carotid arteries that come up into the head, and you have 2 vertebral arteries that come up into the basilar artery in the back of your head. So think of this view as someone lying in the bed, and you're looking down at the top of their head, and you're seeing the blood vessels coming up around their brain. And so there's a circle here. All these blood vessels have collaterals and alternate flow pathways, and they all interconnect. And it's nature's way of making sure that if someone, just because someone might have a bad carotid stenosis and loses this carotid artery, depending on, there's a lot of anatomic natural variability of different people and different preconditioning depending on your history of disease, but there's a lot of redundancy here. And if you were to knock out your carotid, you could still get supply from your vertebral arteries and your basilar artery and through the PCOM here and the anterior cerebral arteries and the anterior communicating artery. So lots of things, but in general, your stroke patterns depend on which blood vessels gets blocked. And I'd say probably 90+% of all the worst strokes are what are called LVOs, large vessel occlusions. And that's where there's an embolus that comes up from, down here is the heart, and then the aorta comes out into the aortic arch, and all these vessels come off the aortic arch, the vertebral arteries, the carotid arteries. And so basically, the worst strokes are all where the carotids here are the biggest, And they also come off the very top of the aortic arch as it comes out of the heart and curves around and goes back down into the chest and abdomen. So have any of you ever been whitewater rafting? No? It's a big thing in New England. But basically, you know when you're whitewater rafting, you don't try to control the boat. You get in your raft and you see where the current takes you. And as long as it's a given day and the water's a given height and it's a certain temperature, there's a guide that goes out first thing in the morning to make sure it's safe, and they know what the current is going to be. Then they just get all the tourists in the raft and, all right, this is where it's going to take you. It's the same thing with embolus. There's certain patterns of flow if the embolus is coming up from the heart, and the most common place, just because of the flow patterns, is for it to go up into the carotid arteries. And when it goes in the carotid artery, the main artery in the brain that supplies most of the things you need to talk and move and speak and all the most important stuff that makes us human, supratentorial, is the middle cerebral artery, and it comes off the carotid and it travels out. Whoops, did I just turn this off? Or? All right, it'll reboot, but those are the ones that make up most of the strokes that people get aphasic, that they just suddenly lose the ability to speak, suddenly lose the ability to move. Those are the ones where you have to be a neurointerventionalist, and the real way to treat those is not with intravenous thrombolysis, with these clot-busting drugs, but the real way to treat those is to actually go in with a catheter that you put up the groin and thread up through the aorta and put up into the carotid artery and thread out into the middle cerebral artery and get all the way out into the middle cerebral artery and suck out that clot, and hopefully they're better. And that's what the real goal of imaging is to identify patients who you need to wake up the neurointerventionalist at 3 a.m. and call the technologist in and spend thousands of dollars to turn on the fluoroscopy machines and thousands of dollars worth of catheter. Every time we open one of these catheters, it's a couple $1,000s. They're very high tech. And so you need to use the imaging to say, is this a patient who I could treat with IV TPA? Or is this a patient who's untreated with any treatment and I shouldn't treat at all? Or is this because their risk of hemorrhage, and what's the rule? First do no harm, that's the Hippocratic Oath. So is this a patient where the risk of bleeding is greater than the potential benefit of treatment? That's what the imaging is about. It's to answer that question. Should we treat with nothing and just medical treatment? Should we treat with intravenous thrombolytic drugs? And by the way, for those of you who know the difference, the standard intravenous thrombolytic drug has always been something called alteplase, streptokinase, but there's a new drug. It's called tenecteplase, and it has a much better safety profile, and that's what we should be using right now, is the tenecteplase. And, or do we call in and do the really heroic thing and start doing this clot retrieval, the EVT, the endovascular thrombectomy? And that's really what, I could almost stop the talk here. That's kind of the take-home message, but I'm a radiologist. I have to look at pictures, so I'm going to spend now time showing you the different technologies and the different pictures and the different ways to do this and what the questions are that we're trying to answer. And these are, again, all the different patterns. And again, even with those patterns, there are a lot of mimics. And for example, if you see, okay, so first of all, what are we looking at here? What are these pictures? This is an MR scan, and it's not just any MR scan. It's a very fancy special MR scan, which is called a diffusion-weighted image. And there are different stages of edema when you make brain tissue ischemic, And that edema has to do, edema is release of water, depending on if it's early disruption of the blood-brain barrier or late disruption of the blood-brain barrier. And it's osmotic effects that the blood-brain barrier breaks and proteins and albumin and things flow out. And when they flow out, water follows, edema follows. But what MR diffusion scanning, like it sounds, what is diffusion? It's when water molecules wiggle around. It's one of the 3 famous papers that Albert Einstein wrote in 1905, his miracle year. He wrote 3 papers. He wrote one paper called The Theory of Special Relativity, which never got a Nobel Prize because it was too controversial and no one believed it. And he wrote one paper on Brownian motion, which described diffusion, and it may seem, put little pieces of pollen in water that wiggled around, and he was actually the first person in the history of humanity to prove that atoms exist. And he did the mathematical modeling, and by that Brownian motion of the little pollen molecules, he was able to do the math and say that there must be these little things called water molecules made of atoms that are pushing against the pollen and making it jiggle. And his third paper, which he actually got the Nobel Prize for, was called the photoelectric effect. And it showed that Einstein actually invented quantum theory. And the reason I'm talking about photons is that for people who are radiologists, this is our bread and butter. Every time we do an X-ray, every time we do a CT scan, we're doing certain energy of photons. And if it wasn't for Einstein's 1905 paper, we wouldn't understand why we use iodine as a contrast agent. And the reason I told you earlier that CT measures density, but iodine is the perfect contrast agent because the outer shell of its electrons absorbs 40 kV electron volt X-ray beams preferentially. It's like Superman and the lead wall with the kryptonite. Iodine looks denser than it really is because it preferentially absorbs the X-ray beams because that's the quantum energy of the outer shell of its electron. And so we use that fact every day. And that is very related to how diffusion imaging works because we're looking at how much the water molecules. So MR imaging has to be tuned to a certain element. You could actually only use MR to look at hydrogen, the way we tune it. You could use it to look at sodium and other things, but we have our MR scanners, the dial set to measure hydrogen. And that's because hydrogen is water. Water is 70% of the human body. It's pretty much in every tissue, bone marrow, even bone. So hydrogen is the right thing to use to make a medical image, but when we're doing an MR scan, we're only really looking at hydrogen. And there's this thing called the sodium-potassium hydrogen pump in every cell, and when the neurons die because they're not getting enough oxygen, because they're not getting enough blood flow, then those dead neurons, the first thing that happens is that that ion pump fails, the water gets trapped in the cell, and that is called restricted diffusion because the water can't diffuse out of the cell. And that's actually what we're looking at on these images. The bright areas mean there's restricted diffusion, that those water molecules are not vibrating as much because they're trapped in the cell. That's what we're looking at here. And there's a lot of different things that could give you restricted diffusion, but when you see it in a pattern like this, like just in the gray matter, tell me what CJD stands for. Who knows? Yep. And that's usually due to this prion protein, and it's related to mad cow disease. I don't know if you guys had the whole beef thing, but we were worried about the beef supply. And I just lost it again. So once you see that, you could also see that in hypoxia or anoxia. So if you have diffuse global loss of oxygen, The gray matter is more sensitive to anoxia than the white matter, so it's the first to go. And so that has a very bad prognosis. Most people on average are dead within 6 months of dementia, but it's rapidly progressive and fatal. And that's CJD. But you could also, this is an arterial embolus pattern. This is both parts of the middle cerebral artery and parts of the posterior cerebral artery. I already showed you hyperglycemia could give you strokes or seizures. Hypoglycemia could give you strokes or seizures. Herpes simplex virus gives you this limbic encephalitis of the hippocampus and the medial temporal lobes. And I should say that not all restricted diffusion is irreversible. But in general, unless whatever caused it is within very few hours resolved, it usually is permanent. It's the most sensitive and specific way we have of seeing acute, severe ischemic change. And we at Mass General were one of the first centers. There were 2 or 3 centers in the world that developed this technique. We were one of them. And when we first presented it to our neurologists, they used to call it the light bulb sign. And all they ever wanted, if a patient came in, rule out stroke, is get your diffusion scan. We need to see if there's the light bulb or not. And it's very all or nothing. If it's severe ischemia enough that there's going to be irreversible stroke, irreversible brain infarction within a short period of time, you're going to see that restricted diffusion. And that's that. And that's what we're looking at here. Okay, and other stroke patterns. And now, the trouble is, you guys in La Serena at the big city hospital are very lucky, because I will tell you there are very few centers in the world, maybe more now, but very few that have MR scanners in their ED that are capable of doing a diffusion MR 24/7 within minutes of the patient coming into the ED. Back when we were doing all this research, I could probably count it on one hand. A few years later, I could count it on 2 hands. And even now, it's very uncommon. And the standard of care, unfortunately, for working up an acute stroke is to get a CT scan. And when you're getting the CT scan, there's a lot of different signs in the CT scan, but what you're really looking for is 3 questions. Question number 1 is there a hemorrhage? And that looks bright on the CT scan. And if there's a hemorrhage, that is 100% an absolute contraindication to any endovascular or intravenous thrombolytic therapy, because the risk of making that bleed worse and doing more harm than good is just too high. So if there's a hemorrhage, you're done. So that's question number 1. And you want a good quality, this is bread and butter stuff. You want a good quality, non-contrast head CT to look for the hemorrhage. Question 1. Question 2 is there a internal carotid artery or middle cerebral artery blood clot? Is there an LVO? Is there a large vessel occlusion? That's question number 2. You need to know that to understand what's causing the stroke. We saw on that first slide, there's a lot of different causes of stroke. And it's not only, they say time is brain. We're not only wasting the patient's time, but we're spending, again, thousands and thousands of dollars and waking up. If you only have, in all of La Serena, if you have 2 neurointerventionalists that are on call every other night, you want to save them for the real thing. You don't want a false alarm. It's like pulling the fire thing when there's no fire. So how do we know if there's a large vessel occlusion? Well, the standard of care right now is a CT angiogram. It's doing a contrast CT and looking at the vessels. And whenever we do a contrast CT to look at the vessels, we also look at the veins. because we want to rule out a venous infarct as well, we might as well. The contrast is there. Let's look at both the arteries and the veins. And what I'm going to spend a lot of time talking about is not just looking at the arteries and the veins, but we talked about how that redundant circle of Willis, that blood supply, has the collateral images. A patient's prognosis in a stroke is very highly correlated with how good their collaterals are. So when we get the CTA, we're actually looking at three things. We're looking at the arteries, we're looking at the veins, and we're looking at the collaterals. And those are the three things. So question number one is there a bleed? And question number two is there a clot? And if there is a clot, how big is it? Now I'll tell you, and I'll get into a little more detail on this if we have enough time, but the standard of care for CTA being required in every acute stroke patient, number one, it didn't happen until we had good treatments. So before we had intravenous thrombolysis or endovascular thrombectomy, there was no reason to do a CTA because it wasn't going to change what you did. So, you know, one of the general rules, again, no matter what specialty you go into, only order a test if it's answering a question that is going to change your treatment or change your management, or else you're wasting money and time. And again, everything I'm saying has exceptions. You know, if it's cancer, you want to know, or Alzheimer's, you want to have prognosis. But quite frankly, before we had levetiximab, and I know I pronounced that wrong, but I hope you all know what I'm talking about. There are these anticholinesterase drugs now that can slow the progression of Alzheimer's disease. And before we had those, we've had for 20, 25 years or more, beta amyloid PET scanning. We've had tau PET scanning. We can make these wonderful nuclear medicine diagnoses of Alzheimer's disease. But at least in the United States, no insurance company wanted to pay for it, and no one was ordering it, because other than prognosis, what are you going to do with that information? You can't change anything. So why do this incredibly complicated, expensive test that no one is paying for, except the patient out of their pocket, when someone is clinically demented, you kind of know what's going on, and you could tell the difference between regular Alzheimer's dementia, frontotemporal dementia, Pick's disease, you know, Lewy body disease with Parkinson's, all those different syndromes. A lot of that you could just see structurally. Although by the time you see it structurally, it's often well established clinically anyway. But before these big clinical trials that prove that endovascular thrombectomy benefited patients, there was really no reason to do CTA. And those big clinical trials came out between 2015 and 2018. And so up until then, CTA was not the standard of care. It was just doing a non-contrast head CT. So what is this finding? This is a hyperdense vessel. And we said that, like, if you have a test tube of pure blood with blood clot, that's 100 Hounsfield units, which is pretty bright. And so this is where the history matters. You see this very bright middle cerebral artery. Is that a blood clot, or is that some streak artifact? Is it old blood clot and not new blood clot? Is it calcification? And that's what I was saying earlier, is that you have to put everything in its clinical context. So there's a lot of things that could be. And when I see it, yes, I'm worried it's blood clot. But then I have to ask, what's going on with this patient? I have to know the patient. And what's going on with this patient is that this is a left middle cerebral artery blood clot, and then I look up on the reason for study in the medical record, and it says sudden onset right hemiparesis and aphasia. And I don't need a CTA with that history to know this is a blood clot. And if thrombectomy is available, let's do it. And for many, many years, this was the standard of care for deciding who gets thrombectomy. And in fact, in 2013, there were 3 big randomized prospective clinical trials, which randomized prospective, that's like the holy grail of clinical trials, the best possible design, that enrolled patients in the trial based on this. All those trials failed because even though this sign is very specific, it's not very sensitive, and you were unable to show that you were able to select patients with imaging who were going to benefit from treatment correctly. And so, and by the way, sorry, it works for the basilar artery as well. Now, this is a very famous paper, this guy named Rydell. For a long time, people were using this as the main criteria. And what he basically showed is that if your hyperdense middle cerebral artery is longer than about a centimeter, 8 millimeters was the exact number, you have a 0% chance of IV thrombolysis alone reopening that vessel. So once you have a very big clot that's very long, you have to do endovascular thrombectomy if you want to get that clot out. But again, this was how people were like triaging patients, but it just wasn't sensitive and specific enough. And this is just to remember, always look for hemorrhagic conversion, and there's HI1, HI2, PH1, PH2, but let's not spend a lot of time on that. And for the radiologists who want more details about our actual protocols and what we do, this is a very nice paper we wrote in Radiographics that really summarizes a lot of this. And actually, this whole special emergency neuroradiology issue from 2019, the whole monograph was on emergency radiology, neuroradiology, so a lot of good articles in that. And so I told you that part of my theme is how good non-contrast CT is for seeing a lot of subtle things. You just have to know where to look and how to look and to window and level it correctly. So for example, this is the insula, and if you compare the gray matter, which is bright, to the insula on the left, which is dark, insula turns out to be a very sensitive marker for ischemia, because it's kind of like the watershed of where all these different collateral pathways meet up in the insula. And so if you see the insula has edema and ischemia, it's like almost the canary in the coal mine. And basically, it's a good indication. How much of the insula is infarcted is actually, if we have enough time, we'll mention some of this at the end, but how much of the insula is infarcted is a very good indicator for how bad the stroke is and how big the stroke is and how big it's likely to get and how fast it's likely to grow. And if you see the less than 20, if 75 or 100% of the insula is normal, you're probably going to do well. And if more than 50% of the insula or more than 25% of the insula is abnormal, that's probably going to be a very big stroke with very bad prognosis. But you have other signs, and you look for symmetry. So, here's the caudate head. You see how it's hypodense and ischemic and edematous on the right, and it's normal gray matter on the left. And depending on the quality of your scan and how much the edema is and how many hours after the stroke, some of these things may be very, very subtle. Some of these things may be harder to see. But in terms of using these findings as a contraindication to IV thrombolysis or endovascular thrombectomy, these are more used to rule out a stroke. And so I said there's 3 things you need to know before you make a decision to treat someone. or at least to treat them with endovascular thrombectomy. And I said those things are, is there a bleed? Is there a hemorrhage? Is there a large vessel occlusion? And the third thing you want to know is, how big is the stroke? And it turns out that historically, based on the old catheters we used to use and what was the standard of care a few years back, if the core of the infarct, the hypodense area of irreversibly dead brain, was already more than about a third of that hemisphere, that was probably too big to safely treat, and the risk of hemorrhage was considered too high. So what are the three questions? The three questions are, is there a bleed, is there a large vessel occlusion, and how big is the stroke? And most of the rest of this talk is going to be about that third question, how big is the stroke? Because that's very controversial, and all these different techniques have different ways of measuring that. You can measure it just with the non-contrast CT, which doesn't happen until very late, because you don't really get that edema until there's blood-brain barrier breakdown and it's a lot of vasogenic edema, and it's already too late. And you could do that with CT perfusion imaging. You give contrast and look at the pattern of the blood flow, of the cerebral blood volume, the cerebral blood flow, the transit time, how quickly that contrast is reaching that area of the brain and how big that area is. So that's another way of doing it. And if you are doing it just on a non-contrast CT, you don't even have to get a volume. You could use this little rule called the aspect score. And you have 10 areas of the brain, and each area of the brain counts as one. And if all these areas of the brain are normal, you get a score of 10. 10 is normal. For every area of the brain that is hypodense, that is low density, edematous, ischemic, you subtract a point. And the general rule of thumb has always been, well, if it's about 30 to 40% of the brain, if more than 30 to 40% of the brain is already dead, then the risk of causing a hemorrhage is going to be too high, and so you probably shouldn't treat. And so the cutoff historically has always been aspect score. So remember, high number is good. So if you had 6 or more, you were probably okay to treat. But if you had 5 or less, you probably shouldn't treat. And this is very crude and very late, and you're just doing it off a non-contrast CT. But there are some tricks you could use. This was actually one of the very first papers that I ever wrote, and it was, right now it might not seem like a big deal because we all know to play with the window and level display settings like on your TV, but at the time, don't forget that when PACS systems, looking on a TV screen to look at your X-ray images is relatively recent. And when I was a resident and a fellow, we were just getting PACS for the first time. When I was a fellow, that's when I wrote this paper. And we had just gotten a PACS system. And does anyone know anything about photography? Do you know what photographic Kodak film is made of? Silver halide that gets exposed to light, and there's a chemical reaction when you put it in the developer, and that's where you get your pixels, your grayscale and your color. And film is really expensive. So like, we weren't allowed to have lung windows and bone windows and soft tissue windows and stroke windows and brain windows. So at the time this paper was written, it was a very big deal that you could change the display setting easily and get extra information more accurately. In fact, just as a very quick aside, back when I was a fellow, we had our head technologist in one of our community hospitals, according to who we had to fire, according to Massachusetts state law, you have to keep medical records for 7 years before you destroy them. And now they're on computer, it's easy. But back then, we had whole buildings that were file room buildings where we put all the CT and MR and plain films and ultrasound and x-ray scans. And we were looking for, again, one of my big take-home messages is serial changes. Look at how patients change over time, how quickly. So we would always ask, let's get the x-ray from 7 years ago and see if the meningioma got bigger. But at this one hospital, the records only went back 5 years. Why can't we get the records from 7 years ago? I want to see it. It turned out that the head x-ray tech had a little side industry going, was melting down the x-ray film, getting out the silver and selling it to pawn shops and making it a lot of money. And then that couldn't happen anymore. But that's how expensive x-ray film was, and that's why this is kind of a big deal. The other thing I will say is we talked about the hypodensity. For the radiologists, we talked about the hypodensity being edema because water is lower than gray matter and white matter, and it could be very subtle. But there is one other thing. I oversimplified it a little bit because that's why I spent a lot of time talking about how many Hounsfield units blood is and how you could put a cursor on and measure blood hematocrit in the aorta, and it's kind of dense. Because part of it is even before you get any edema, if there's a LVO, a large vessel occlusion, and no blood is getting there, then the Hounsfield units drops a little bit because it's a blood pool effect. So part of the very, very early density that would correspond to what you see on the diffusion MR is really not even edema at all. It's a blood pool effect. I just wanted to, it's a CBV effect, and I just wanted to make that clear for the radiologists, so I'm not oversimplifying it, but just by playing with the display settings, you could see this. And we had a lot of fun this morning looking at pictures of Marilyn Monroe and Albert Einstein. And I'm going to tell you why, because one of the tricks for radiologists is that when you magnify an image, you're magnifying noise more than signal. Unlike MR scan, the signal to noise ratio is much greater in CT. CT is just noisier images. And so when you have a noisy image, it actually turns out when you magnify an image, you're magnifying the noise more than the signal. And so when I'm first looking at a lot of scans, I like to look at them tiny little thumbnail size format, like 12:1, 6:1. And so take a look at this, and you could probably all see that there's more loss of gray-white attenuation on the left hemisphere than the right hemisphere. But don't you think when you make it a little smaller and you squint, you're averaging the noise and you see it just a little better. And this was a very famous thing that you could find on the internet, but I have a friend who took a picture of Marilyn Monroe and added a lot of high frequency noise to that picture, and I had the same picture of Albert Einstein and added a lot of low frequency noise to the picture, and then took those two pictures and just superimposed them, put them on top of each other. And when you look at it and it's very tiny and you kind of squint, you're getting the high frequency, high contrast resolution information that your brain processes, and that looks like Marilyn Monroe, right? But same picture, same exact picture, I'm just blowing it up. I'm just making it bigger. When you make it bigger, you see Albert Einstein. So this is why I like to first get an overview of all the scans and look at them, little thumbnails, little small, and I could cross-correlate them with the sagittal and the coronal and the axials. And we're actually working on some projects now, but I'm going to give you the quick take-home message, and if the radiologists want to discuss this in more detail, come to the technical talk that I'm going to give on Wednesday. But it actually turns out that the diffusion scan shows you that very early blood pool restricted diffusion very nicely and is very sensitive for early stroke, but can't distinguish how old it is. Can't distinguish these different timings. And the same thing with FLAIR. FLAIR is very accurate for vasogenic edema, but it's very all or nothing. You either have big blood-brain barrier breakdown and let the albumin leak through and the water follows it, or you don't. So FLAIR can really only see the severe vasogenic edema stage. DWI picks up acute stroke very early, but only picks up that there is a stroke and doesn't help you distinguish these stages. But it turns out the CT changes are linear. And of all ways to time the stroke, CT, even though the findings are a little more subtle, actually gives the most quantitative information about how established the stroke is physiologically. And again, the goal is to replace, so we're going to talk a little bit about the clinical trials, and I'm going to start talking a little bit faster, but because I have a lot still I want to get through. Do I have a hard stop at any time? Any given time? What time do you absolutely not want me to go past? Because I'm going to pace it differently depending on, but okay. So basically, the whole idea, I said the idea of imaging is to decide who gets treated and how. But it's even more than that. Right now, we have these arbitrary rules, like only give IV TPA up to 4.5 hours based on the Lancet trial, or only do thrombectomy up to 8 hours, and then my friend Raul Noguera came out with the Dawn trial and said, well, if you use the algorithm for imaging that I'm going to show you, you can actually safely thrombolize, give AVT up to 24 hours. But all these things are still very arbitrary clock times. And depending on your collaterals, if you have good collaterals and you have bad collaterals, then if I have a 90% reduction in blood flow for you for 30 minutes, and you have bad collaterals, by then it's probably too late. And if you have great collaterals with an intact circle of Willis and completely symmetric ways for the blood to get to that part of the brain from other places, you could have a 90% reduction in the infarct core for 24 hours and you still want to reopen it. Because the treatment with endovascular thrombectomy, core, by definition, core means dead brain. What's dead is dead. The reason for doing the treatment is what's still at risk, what is the penumbra, and what do you want to make sure you're restoring the blood flow to so the stroke doesn't get worse. And so you don't lose that penumbra. That's the strategy. And so this was all a very long-winded way of saying that the goal of imaging is not only to decide who gets treated and how, but the goal of the imaging is to decide the answer to that question based on physiology and blood flow that is unique to that individual, and not just some arbitrary clock time that is based on a clinical trial that is the average of hundreds of patients. So it's true. On average, once you see flare on positive on an MR scan, that happens at about 6 hours. And that means there's vasogenic edema and it's probably irreversible. But do you know what the 95% confidence interval is? It's probably 30 minutes to 12 hours. Some people, their flare turns positive in 30 minutes if they have no collaterals and an isolated hemisphere. Some people, their flare may not turn positive for 12 to 16, 18 hours. Yet, if you do CT perfusion, those two patients are going to look identical because they all have the same 90% reduction in blood flow. But how resistant they are, the trouble with CTP is when you see low blood flow, no matter what threshold it is that Rapid is telling you to use, Rapid, by the way, is the software used to analyze CT perfusion. Rapid can't tell the difference between core and penumbra. When it says the 70-30% reduction is the core and everything more than that is the penumbra, it's taking the average of thousands of patients who are in this clinical trial. So it's correct. On average, 30% reduction in blood flow is core. But for any given individual patient and for any given number of hours after the stroke onset, that 50 ml lesion size, 30% reduction has enormous standard deviation. It's enormously variable. You're just looking at an average. So CT perfusion tells you about blood flow. It is not accurate for reliably distinguishing core from penumbra. It's useful for a lot of things, but it's not useful for being the only thing you use to make a decision about the core size if you're trying to decide who to treat. All right. And a little aside, I've been working on some AI things for this. Remember, augmented intelligence, not artificial intelligence. And basically, I want everyone to take a look at this. This, by the way, Raul Nogueira, who did the Dawn trial, is Brazilian, but he lectures a lot in Portugal, and I've worked on a lot of projects with him. And he invited me to speak at the Lisbon Stroke Summit a few years ago. So this was a case I presented. I want all of you to try to tell me which is the abnormal hemisphere. There's a stroke here. There's very subtle ionic edema, early vasogenic edema, maybe a little blood pool effect. Look at the gray-white. Look to see if you could tell which hemisphere is abnormal and how big that area is. And you could tell some of it if you really squint, maybe. But we programmed an artificial intelligence program to look at this, and we were able to train it to be much more accurate than the human eye. And when we asked the artificial intelligence program to look, this was the gold standard diffusion image, and this is what it outlined. And remember, our protocol is we do CT, CTA, plus or minus CTP, and diffusion. So the diffusion is done 15 to 45 minutes after the CT, which might be part of the reason it looks a little bigger. But we train this AI to be very, very sensitive. And why were we able to train it? I just want to give you guys a quick lesson on AI. And I'm just going to, there's a lot of things I could say, but I think the important thing is to remember garbage in, garbage out when you train an AI software. And that training artificial intelligence is only as accurate as the data you use to train it. And you need to use platinum standard ground truth. So a lot of AIs are being trained for radiology because the ground truth that they're using for the training is how a radiologist read it. But radiologists have intra and inter-observer variability, and they're often wrong, and they often don't outline things accurately. And so the reason we were able to program this artificial intelligence to be almost as good as diffusion imaging in reading a head CT for subtle hypodensity, and much better than humans, is that we trained it with a unique data set because we had about 20 years almost worth of thousands of CT diffusion MR pairs. And so we trained the CT read using the MR diffusion as the ground truth. And so because that's the way we trained it, it found things in the image that maybe were little image noise or texture things that it could detect that the human eye couldn't detect. And so we actually, the ROC curve in the blue was the computer, and the dotted red line was the experts like me who have decades of experience but couldn't see things that the AI was able to see. And that's Raul, and this is just a small, what I just showed you is just a small piece of it, but he's been predicting for years that there's probably so much information just in the non-contrast CT that if you look hard enough, that maybe we've come full circle. And I think we're always going to want to do the CTA to look for the arteries, the veins, and the collaterals, but that in terms of measuring core, there may be enough information just in the non-contrast CT to get the information you need to make a treatment decision without doing other fancy things to measure core. And there are some false positives. So here's the globus pallidus and putamen here, high density, gray matter. You don't see it here. So is this a proximal M1 right middle cerebral artery perforator stroke with early edema? Well, no, because this patient was just tilted in the scanner, and when you went down to the lower slice, it was fine. So that's why I'm saying always look at everything. You're responsible for anything on the film. You're responsible for it. If there's a Pancoast tumor in one scout image, you should find it. And here's another thing. We were thinking there's some subtle hypodensity right here, kind of at the gray-white junction. Is that a little multiple sclerosis plaque? Is that some early ischemic change? And we got the sagittal and the coronal, and it turned out that one of the detectors was out on the scanner, and so when it reconstructed, it had this whole beam that was not showing up correctly. But if you're just looking at the axials, you don't know that. When you look at the sagittal or coronal, you can figure it out. So there's a lot of reasons to always look at all three planes. Here's a good example. Why do you always need coronal and sagittal views? Because remember, if you're a radiologist, one view is no views. You always need at least two orthogonal views. And this is not what you think. This turned out to be this. But if you didn't look at the AP, you would have misinterpreted. So, all right. I have a lot here on spectral and dual energy CT, and this is not the right audience for it. I will just say that there is a new, actually this isn't that new, but it's the idea of coming back to that Einstein 1905 photoelectric effect paper with the iodine and the quantization of energy values from light and photons and X-ray beams. So it turns out DECT stands for dual energy CT. If instead of standing with one X-ray tube or beam with a range of energies, of photon energies of the X-ray beam, if you scan at two different energies, you almost go from being black and white to color TV. And so in other words, I said at the very beginning that CT measures density. So how bright the pixel is how dense the tissue is. And it's a monochromatic grayscale. It's like a black and white television. But if you scan at 2 different energies, different elements absorb different energies in different amounts. And by combining and averaging the information from those 2 different energy beams, I could now tell the difference between calcium and iodine. Or I could tell the difference between blood and calcium, or blood and iodine. And so it's almost making CT more like MRI, where you could do certain individual elements. You know, with CT, there's really only 4 things we could see now. Air, which is negative 1,000 Hounsfield units. You know, fat, which is negative 50 to negative 100. Water we said is 0. Soft tissues have a little range and they're all squished together. And then calcium up around 1,000. But with dual energy CT, you can figure out the difference between a calcified uric acid crystal from gout, which is not really calcified, it's high density, it's uric acid, because you could do what's called material decomposition. And you could actually, based on that different absorption of the beams at different energies, do CT spectroscopy. And we have this in RED in both our CT scanners, and it's not a killer app, it's not amazingly useful, and the main reason right now it's not amazingly useful is that the routine quality of the bread and butter stuff, like just a standard non-contrast head CT, is not as good because there's a lot of post-processing of those images. But for problem solving, it's great. And so basically, again, we could tell iodine versus calcium versus hemorrhage. And here's an example where that on the far left was some high density. And the question is this blood or is this calcification? Is this blood or is this calcification? Well, we could do a calcium image and you see the calcium but nothing else. And then you could do a calcium subtraction image where you still see the high density there. So, I mean, this is not a diagnostic dilemma, but it's just an example showing how you could separate out blood and calcium. You could do stuff like that. And we've written a lot of papers on this. And even better, I'm sure the neuroradiologists get these scans after a thrombectomy case. I don't know how much thrombectomy you're doing, but even IV TPA, if you have contrast and you've just done a procedure where you might have caused a basal ganglia hemorrhage. So this is a stroke patient. The question was, post-treatment, you have all this hypodensity and you have this very high density. Is that blood or is just blood-brain barrier breakdown with iodine leakage? And by doing the spectral CT, we could create a virtual non-contrast image. And you see here, it goes away completely. And then we would take the pure iodine image, we could paste it back on. So this was not a basal ganglia hemorrhage. And this would have changed management. This was just iodine blush from blood-brain barrier breakdown. Okay? And I was very privileged. I love this. I got to visit CERN, the Large Hadron Collider, where the Higgs boson was discovered. And the reason I visited CERN is that every 2 years, for the past couple of years, they've been having a big CT scanning meeting there. And they've created something new called photon counting CT. And now there's just a few vendors that have it out. It's basically the same thing as dual energy CT, but it's much better spatial resolution, contrast resolution, temporal resolution, because it's using the same detectors as these Large Hadron Collider that discovered the Higgs boson. This is like 300 feet underground. Go Google Atlas Detector CERN, and you'll see a person looks like this tiny little thing standing next to this big sphere. Those are now the same detector technology that are being used in these CT scanning, which is why they have this at CERN. And what is the relevance of that to stroke? Well, if you could do this kind of very high spatial resolution spectral CT imaging and tune those virtual monochromatic single KV images to the K-edge, the stopping density of like edema, then you might be able to make the edema pop out. And you might not even need perfusion imaging. You might make it much more apparent. And this is all very early days. It's all work in progress, but it's something that we're working on. And so I'm going to, just so you know, in case people are getting hungry for dinner, it's 5:43. I will make sure I'm finished by 6. So we'll have at most 15 more minutes. Is that good? And we'll cover everything. We'll cover everything, even if I have to talk a little faster. I've been talking slow for the translator. Okay. Okay. So now some of the clinical context. So that's kind of the imaging, some of the clinical context. So this was before the Dawn trial that extended the time window to 24 hours. This was our stroke imaging algorithm. We've been doing this for decades, and we've written papers on it. Gil Gonzalez, our chief, really pushed this, and it's been great. And again, we're answering 3 questions. Non-contrast CT, is there a bleed? CTA, is there a proximal occlusion? But we're also going to look at the veins and the collaterals, since we have that information anyway. We use everything we have. And then our protocol for many, many years was to just get the diffusion to look for the core, because it's the most accurate, and because we could, and we were lucky. And it does turn out, we've written a lot of papers showing how much more accurate it is, and how much better it is for selecting patients, including the ones who should be included, excluding the ones who should be excluded. And that's why we always kind of were ambivalent about CT or MR perfusion. We didn't think we really needed perfusion. Again, 3 questions: hemorrhage, occlusion, core size. Those are the 3 questions. Endovascular therapy up to 8 hours based on the 2015 clinical trials, and up to 24 hours based on the Dawn and Diffuse 3 after 2018. And what are those treatment options? Again, I already said, it used to be alteplase, but now we're doing tenecteplase, a little better safety profile. Between the biggest change when Dawn went from that 6 to 8 hour endovascular thrombectomy to the 8 to 24 hour endovascular thrombectomy was it got a little more conservative. So instead of saying a third of the MCA territory, aspects of 6, about 70 mLs, the cutoff in all the big clinical trials to just be safer was 50 mLs. And the main reason for designing it that way was only because the FDA wasn't going to be happy unless they did, because we had therapeutic nihilism. You know, you basically, the whole reason for doing a trial is that you don't know. If you think you already know the answer, you shouldn't be doing the trial. So the FDA said, since we don't know, let's err on the side of being a little safer. The trouble is that once you do a clinical trial, people make a lot of bad logical assumptions. And the 2 biggest pieces of faulty logic from doing a clinical trial is, number 1, making inferences about things from the trial that were not intended when the trial was designed as the primary outcome being measured. And number 2, we already talked about, is clinical trials are to prove that a treatment is better or worse or the same, or at least non-inferior or non-superior. Clinical trials, though, don't tell you how to treat individual patients. They tell you for an average patient, if you do this, you're better off doing this than that. For the average patient, but patients are not averages. And that's what we mean by personalized medicine, and that is part of the goal of the imaging. Part of the goal of the imaging is to treat patients as individuals, not as averages. Because if you're just going to say, we're going to do this up to 4.5 hours on everyone, and this up to 24 hours on everyone, there's very little need for doing anything other than ruling out the bleed. The whole idea of all this advanced imaging is, can we replace this arbitrary clock time with something more rational and physiologic that lets us treat the individual patient? And so the 2013 trials all failed because they didn't use advanced imaging, CTA. This one slide I could probably give a 2-hour lecture on, but let's just say that the 2013 trials failed, but when we finally started using, so all these trials, all published in 2014 in the New England Journal of Medicine, all showed that thrombectomy works, that EVT works. And that was the goal of the trials, to show that EVT works. They all used non-contrast CT, they all used CTA, but they all used a different way to measure the core. And here's the other logical fallacy, is that, and I forget if I had, and then it went on to 6 to 24 hours 2 years later in 2017, 2018, and they said, if you use this imaging algorithm, you could actually safely treat not just up to 8 hours, but up to 24 hours. So we expanded that arbitrary time window just by looking at the blood flow, diffusion, collateral, physiology. And we extended that window. And so at that point, in 2017 and 2018, at least in the US, it became the standard of care. And when I say standard of care, I actually mean that literally, because those clinical trials had to be approved by the Food and Drug Administration, and the FDA said, well, we have to put on the package insert that if you're going to select patients for this treatment, you have to do it using the same tools as the clinical trial. So it actually said that you have to do the CTA. So it did literally become the standard of care. And I'm going to skip this, but part of the nuance of what I was just talking about is what we really try to do is break patients up into 3 groups. And you're going to see why this is now very relevant and important. So up until really just the past year, we would treat patients in this green category, only treat patients in the yellow category if there was some special overwhelming reason that we were willing to risk it, and we would not treat patients in the red category. And it's not about risk versus benefit of hemorrhage versus improvement. It's basically about how likely are they to benefit in a clinically meaningful way. So these original 2015 trials, they were all based on a good outcome. And so really, the only patients that are ever going to have a good outcome are the ones with proven to benefit in this category. And by the way, if you're looking at this, this is an old slide. Some of these things have changed a little bit, but it just means to give you the idea that you're basically saying likely to do well, likely to do poorly, and in between. But 80% at least of all patients who are stroke patients coming into the ED actually don't fall in the middle, they fall into one of the extremes. It's kind of all or nothing. You either have good collaterals and you come in the ED with a good prognosis, or you have bad collaterals and you're already kind of hosed. And so, wrong one. Just very quick aside, remember, you're looking at the CTA. We do the CTA down through the mediastinum. to see the great vessel origins, because we want to look at that 40% or 20% of strokes where maybe the embolus came from atherosclerotic disease at the arch. And so when you have a scout image, if you see that the patient has a right mainstem bronchus endotracheal, you may be the only person who knows that because our protocol right now, because time is brain and speed is of the essence, when we have the EMTs bring in a patient with a stroke who may need IVT or EVT, they go straight to the CT scanner. They don't stop and get their bloods drawn or get a physical exam or anything else. And so they're pumping on the intubation. If you see something, say something. All right? Let me give you this quick example. This was very lucky because we had this 60-plus-year-old woman who was in the hospital and has some arrhythmia, had a history of arrhythmias, got very emotional because she was visiting her husband who had been hospitalized for something completely different. And she was very upset, and she went into a little atrial fibrillation, and she threw an embolus, and right in the hospital, we brought her right down to the ED. So she has, excuse me, she has the hyperdense vessel, and it's pretty long, and she's already in the ED. But I will, and this is an important point we're going to come back to, is that her non-contrast head CT, gray-white differentiation, hypodensity, and of course, we're not using that little AI program yet clinically, it's still research. But as far as the human eye could tell, this was stone cold normal. There was no ionic edema, there was no vasogenic edema, there might have been cytotoxic edema, but here's the thing, we didn't want to waste time doing an MR because the head CT was so normal. There was clearly no significant edema, and the key word there is significant. So even if there was subtle edema, it wouldn't have changed what we did. Because why? Because the half-life of IVTPA or doing the endovascular thrombectomy is very quick. The half-life of IVTPA is probably 60 to 90 minutes. So if you could get in, get out, even if she was going to develop a big infarct in the MCA, she hasn't yet, and if we could treat and get rid of the clot and cure it before that happened, then our reasoning was we wouldn't have to worry about it. So we wouldn't have to worry about that hemorrhagic risk, and we got the CTA, and not only was there a vessel occlusion, but there was no contrast reaching more than half the territory at risk of the middle cerebral artery. And so this is what's called a malignant pattern. And normally, a malignant collateral pattern falls into that red category. But this patient had a stone cold normal head CT and was very, very early. And in this case, green means go. It's like Boston traffic. Green means go, red means stops, orange means go fast. That's how you drive in Boston. And so basically, let's not waste any more time getting fancy perfusion or CTP. If it's not going to change what we're doing. Her brain looks good. She's got malignant collateral pattern. Let's just see if we could open that vessel as quickly as possible. And we did. And that was her 48-hour follow-up brain MR, which the neuroradiologist may see some subtle restricted diffusion, but it was pretty much a complete save. Pretty much a complete save. And so here's one of the things that I want you to remember. It's not to not do perfusion imaging, but that perfusion imaging is probabilistic. And the best way to define these things is that I like to think of the definition of DWI restriction as infarct is likely, even if you could immediately in that moment reperfuse the patient, once you see restricted diffusion, it's probably going to infarct. Whereas the difference is if it's collaterals or CTP, it means infarct is likely unless not despite, but without immediate reperfusion, which is why in this patient, when we saw the bad collateral pattern, we said, go fast. And the rest is just hypoperfusion. It's not necessarily at risk, but TIA patients often fall in that last category. A TIA is where you have some transient deficit, but it's not enough to cause a stroke, and when the hypoperfusion gets resolved, the patient is functionally normal again. All right? I want to say one quick word about time is brain, because here's a patient, this is what I was talking about earlier, 2.5 hours post-ictus, horrible collaterals, big restricted diffusion of the whole hemisphere. Here's a patient 8 hours post-ictus, great collaterals, tiny infarct growth. Think of these two patients as twins. The only difference is their collaterals. And so that's why every patient is an individual, and if all you're going to do is look at the clock time, you're not making a rational, informed decision. There is so much information in the imaging, and we actually graphed out like 186 just random stroke patients, consecutive all comers. How many hours post-ictus? How big was their diffusion lesion? It's all over the place. The error bars here are like twice the size of the infarct core. So just arbitrarily looking at the time doesn't mean much. I'm not going to spend a lot of time talking about the details about this malignant collateral pattern, but part of my message is all of the CT perfusion has a lot of technical limitations, a lot of physiologic limitations, and a malignant collateral pattern where you have more than half the brain getting low blood flow is really equivalent to a big perfusion deficit. And we did this study where we looked at the collaterals, and if they were symmetric, it was that green category, likely to benefit, and if they were malignant, it was the other. And how do you tell symmetric? Well, if by squinting, you can't tell which is the abnormal side, it's probably symmetric. If you can't tell which side has the occlusion, and remember, sometimes you see more vessels on the ischemic side, because just before the collaterals fail, you have vasodilatation and you have high CBV because autoregulation, the brain is trying to compensate. So the vessel's dilated, you have all these high, low venous outflow because there's not as much forward perfusion pressure, and you might see what looks like more vascularity on the ischemic side. Okay, and of course malignant pattern, baseline in 24 hours, much bigger infarcts, and so we like looking at the collaterals. We talked a little bit about the predictive value of the insula, and you could almost get the same relationship as with the symmetric and malignant collaterals, as just looking at, is the insula infarcted more than 25% or less than 25% or 50%. So all of those things are penumbra loss, and I am going to spend 1 or 2 more minutes just to finish up, bringing you up to 2025. And over the past 2 years, there have been 5 or 6 big clinical trials asking the question, what would happen if we stopped looking at core at all? What if we just looked at no bleed, and is there a large vessel occlusion? And we ignored the core size. And you know what? With the newer catheters and being very careful about the patient selection, it turned out that it worked. You could see I was a co-author of this. This is the American Heart Association Science Advisory on Large Core Stroke, just published in 2025. And it basically said that, you see, they asked a different question. In the 2015 and 2018 trials, the question was, who's going to get a good benefit? That was the question. And that's where they came up with that 1/3 MCA territory and less than 50 to 70 mLs. But these big trials were a different question. They didn't ask who was going to have a good outcome. They asked who was going to have a better outcome. Now, very clearly showed that endovascular thrombectomy has a better outcome than no endovascular thrombectomy, even taking into account that those patients had an increased hemorrhage risk. Overall, but again, those were dealing with means. You know, if you're the individual patient who gets that hemorrhage, then you shouldn't have done it. But on average, you're better off. But the other big thing that I underlined here is just to be a little careful, because when you did the meta-analysis and pulled the data, there weren't really enough patients in the aspects less than 3, and there weren't really enough patients greater than 12 hours to say anything definite about the very low aspects or to say anything definite about the very late windows. And so, but certainly down to about an aspect score of 3, you're better off with thrombectomy than without it. But that said, you're talking about, I don't know if you guys know the Modaffin-Rankin scale. It's basically 0, 1, 2, 3, 4, 5, 6. It's a 6-point scale of activities of daily living for clinical outcome, 3 months, 6 months, a year. And 0 means normal, 6 means dead, 5 means like, you know, in a vegetative state. 4 means, and not quite a vegetative state, but really severely disabled. So in the 2015 trials, 2018, they were just looking for a 0, 1, or 2 outcome. And that was considered a good outcome. Now, if you take a patient aspect score of 3, you might be able to take them from a modified Rankin score of 5 to a modified Rankin score of 4, and that might be enough to have some meaningful quality of life. But on the other hand, if it's a 90-year-old who's very frail and has multiple other medical problems, then maybe it's better not to be on a ventilator for another 2 years, just so you could gain 1 modified Rankin point. So that's where you really need to have some nuanced decision making. So I am absolutely not saying that this means you should treat everyone, but I am saying that there's a lot of information in the non-contrast CT, and there's probably enough information for you to make these decisions in an informed way. And I don't think you're adding a lot by doing CTP or even diffusion, because I don't think you have to be that accurate at that point. All right? And in fact, you can see here, Greg Albers is the chief of stroke neurology at Stanford. He is also the guy who founded the company Rapid. And so he really doesn't like coming out and saying bad things about perfusion, because he invented a lot of the perfusion techniques, and he's a big proponent of them, and they're useful for certain things. But again, they shouldn't make the difference between treating and not treating. And even in this late window, he just recently had a paper showing that in the late time windows, CTP is inaccurate. And you might even have to use a stricter cutoff, because when you're more hours out, it's more likely that even a less reduction in blood flow may have caused an infarct. But it's, as we said earlier, it's all probability. And there's big error bars, and in any given individual patient, these things could vary. And there's a lot of variability. And in addition to that, we actually showed in an abstract that before I became a radiologist, I did an internal medicine residency at Boston City Hospital in Boston. And in order to get into radiology, I wanted to do a research project which helped me get into radiology. And I did a project with Dr. Ackerman, who, by the way, literally invented carotid ultrasound. He did the first carotid ultrasound in the world. And he was my mentor. And he did a big study of PET scan in stroke, and he looked at cerebral blood flow, cerebral blood volume, metabolism. But in 1989, there were no treatments. And so most of these patients were actually treated late. We only had 5 patients within 6 hours. But even back then, he made the point, looking at this PET blood flow study, that what happens, the reason CBF also has problems in the late window is that you start getting collateralization, peel collaterals, into already dead brain. And so the CTP underestimates how much dead brain there is because you start getting flow in the periphery. And so a lot of this was known. So why might CTP be good? Because if you're the neuroradiologist and it's 3 a.m., and if you don't want to get called to come look at the non-contrast head CT and drive into the hospital at 3 a.m., if you have the perfusion, it's a nice color. You see exactly where the stroke is and how big it is. But again, the thing to remember about this is that's useful information, especially if you're not trained as a neuroradiologist to look for all these subtle hypodensities. But it's not quantitative. It's a nice diagram of areas that have low blood flow. Those reds and yellows and greens cannot tell the difference between what is definitely core and definitely salvageable, definitely penumbra. And I think that's the big take-home message. And lots of different programs. It turns out they're all relatively equivalent. You don't have to use Rapid, Syngavia, Viz.AI, lots of others. These are the 2 we use. And a lot going on now with the basilar artery, which is also a hot topic. And you have a little more of a time window on basilar artery. Another big thing that the jury is still out, but probably the answer is more likely yes, but a little different clinical trials, depending on the inclusion criteria, are saying things that are slightly different, is whether IVT plus EVT is better than EVT alone. And the answer is probably yes for certain patients. And this is now our new, most recent algorithm, but I'll basically summarize it it's a very simple algorithm actually, much more simple than this makes it look. And we get a CT and a CTA on everyone. If we think they're a treatment candidate, if the neurologists want the CTP, we do it, but we don't feel we have to do it to make the decision. And if, for whatever reason, the patient is not an EVT or IVT candidate, then we'll go ahead and get the diffusion just to make sure we're not dealing with a stroke mimic and we're getting a definitive diagnosis and we make sure that we're estimating the core correctly. But if we think they are a treatment candidate, especially after those large core trials, just go for it. Just go for it. And I think that's it. Thank you. Okay. Okay. Thank you.
Bueno, le damos las gracias al doctor.
Oh, should I leave the phone?
Gracias, doctor, por la excelente presentación. Le hemos preparado un regalo. La doctora Alejandra Lago, la doctora Patricia Sangüesa. We have a present for you. A present from you.
Okay. I like that. Thank you.
Thank you so much for being here. Doctora Alejandra Lagos. A picture? Maybe come here for a picture.
Pero nos ponemos acá, ya. Pero vale. Sí, pues.
Muchas gracias por la jornada, así que tengan un buen retorno y espero que tengan un análisis de lo que hicieron y sáquenle provecho a este momento. Así que muchas gracias y sigan estudiando y aprovechando.
So many people view the